The skeleton of the upper limb consists of the humerus of the arm, the ulna and radius of the forearm, the carpal bones of the wrist, and the metacarpals and phalanges of the hand. Each arm articulates with the axial skeleton at the pectoral girdle, which is analogous to the pelvic girdle in the lower limbs. The pectoral girdle includes two bones, the clavicle and the scapula, and we're going to begin with those. Let's begin with the clavicle. The S-shaped clavicle, which articulates with the sternum, connects the upper limb to the axial skeleton. Each clavicle originates at one of the clavicular notches at the superolateral border of the manubrium of the sternum, just lateral to the jugular notch. This end of the clavicle is called the sternal end, and from this position, the clavicle is going to curve in an S shape, both laterally and then posteriorly as well. At the very end of it, it's going to begin a slight curve anteriorly to the point where it articulates with the acromion of the scapula. This is referred to as the acromial end, and notice that it's broader and flatter than the more stubby and short sternal end. Let's take a look now at this bone if we take it off of the skeleton. This is a right clavicle that has been removed from the skeleton, but you can still pretty clearly distinguish between the sternal end and the acromial end. That acromial end is going to be very flat, and the sternal end is much kind of stubbier and thick in shape. Initially, recall from that sternal end, we're going to see the clavicle curve laterally and posteriorly before a small little anterior oriented turn at the acromial end. In general, the clavicle has a relatively smooth superior surface that lies just beneath the skin, and then a more rough inferior surface where muscles and ligaments are going to attach. I want to draw your attention to this small little structure here that's called the conoid tubercle. Now, the conoid tubercle is a small rough projection located on this inferior side near the acromial end, and this serves as an attachment point for the corticoclavicular ligament, which is a very strong ligament that helps to stabilize the shoulder. In fact, shoulder separations result from a stretching or a tearing of this ligament. So as we mentioned, the pectoral girdle is going to articulate with the axial skeleton via the clavicle at the sternoclavicular joint. This is the first synovial saddle joint that we've encountered in this course. And although it may look like a very small point of attachment for such a large appendage, support and stability are provided to this articulation by multiple strong ligaments. In fact, if you were to fall on an outstretched hand, the clavicle will actually fracture before these ligaments that are supporting this joint would actually tear. Now, the acromial end of the clavicle is going to articulate with the acromion of the scapula, and this is going to be referred to as the acromioclavicular joint, which is structurally classified as a synovial plane. The scapula is a broad, flat, triangular bone that has several large projections extending from it that provide surface area for muscle and ligament attachments. At the lateral end, you can see both the larger acromion process as well as the smaller coracoid process, both of which project anteriorly. Acros is the root of the word acromion, and that's actually Greek meaning topmost. And so you can see between the two, this is the one that's the highest up. Think about an acrobat, that comes from the same root. In a circus, an acrobat would be the topmost performer, flying up the highest. Coracoid actually comes from a Latin root that means raven-like or hooked like a raven's beak. The acromion process is actually a lateral extension of the scapular spine, which you can see running across here. And the scapular spine is something that you should actually be able to feel underneath the skin of your own back pretty easily. If you were to palpate that spine laterally, you should as well be able to feel that acromion process on your own body. Let's go ahead and start by reviewing some of those features that we saw on the skeleton as a whole. So if we were to look at the posterior side of this scapula, we can see the spine that's going to terminate at the lateral end with the acromion. And then just a little bit anterior and inferior to that is where we're going to find that hooked coracoid process. The scapula has the body of the scapula has a triangular shape to it, and it has three fossa, two on the posterior side, above and below the spine, and then one on the anterior side, and they're based on their relative locations. So for example, let's start by finding our spine here. This fossa here that is above the spine is referred to as the supraspinous fossa. Right below the spine is going to be the slightly larger infraspinous fossa, so inferior to the spine. And then on the anterior side is where we're going to find the largest fossa, and that is the subscapular fossa. Why the sub? Because technically that means underneath. Keep in mind that if you recall on the skeleton, the scapula isn't oriented directly in a superior inferior direction. It has a little bit of a tilt to it, and so this is the surface of it that is kind of considered to be underneath, right in between the scapula, and then the thoracic cage is going to be very close to that. Now these three fossa are going to serve as origins for three of the four rotator cuff muscles, which will be conveniently named based on the fossa that they occupy. So we'll come back to those muscles in lesson 13. The scapula also has three borders and three angles, also conveniently named based on their anatomical orientations. So border-wise, there is a superior border to the scapula, a medial border to the scapula, and a lateral border. Angle-wise, we have an inferior angle, a superior angle, and then the lateral angle of this triangle. The lateral angle is composed primarily of the cup-shaped glenoid cavity, which you can see right here. And this cavity is going to articulate with the head of the humerus, which is the long bone of the upper arm. This articulation that's going to occur here at the glenoid cavity, also sometimes called the glenoid fossa, is the glenohumeral joint. And this is usually the joint people are talking about when they refer to the shoulder. I'd like to point out that this glenohumeral joint is the second of only two ball and socket joints in the body. It's kind of analogous to the head of the femur articulating with the acetabulum in the lower limb. However, the acetabulum of the os coxa is much deeper than the glenoid cavity of the scapula, making that glenohumeral joint much more shallow. And this leads to kind of a trade-off that we pointed out when we first introduced skeletal articulations. So this shallow joint means that there is less stability, but with that comes the benefit of greater mobility. So the shoulder joint actually has the greatest range of motion of any joint in the body. But in addition, I'd also like to point out that the flexibility of the shoulder joint is even greater due to the fact that the sternoclavicular joint can change the position of the scapula relative to the thorax. So it kind of enhances this flexibility. If we look again at that glenoid cavity, we're going to find two tubercles that are associated with it as well. We have one rough patch here down below, and then there's also going to be a smaller one up above. Think about these as being oriented. If the glenoid cavity were a clock, it'd be located at 6 o'clock and at 12 o'clock. These are tubercles, and this one up here at 12 o'clock is the supraglenoid tubercle, and then the infraglenoid tubercle. And both of these rough patches are going to serve as points of attachment for muscles that move the arm. The last thing I'd like to point out here is just this little notch that's kind of hiding here up on the superior border. This notch is referred to as the suprascapular notch, so the notch that's above or superior to the scapula. So reviewing these structures on the larger skeleton as a whole, we can see the long medial border of the scapula, the slightly angled lateral border, and then the superior border would be up here on top. We have a superior angle, an inferior angle, and then the lateral angle is going to be between that lateral border and the superior border. We can see our spine again that we've already looked at, and then we've got our infraspinous fossa and our supraspinous fossa. Turning this a little bit here. From this angle, you can see the glenoid cavity or glenoid fossa, approximately where the supraglenoid tubercle would be. Here's the infraglenoid tubercle, and you can get a good view of the acromion curving around there. Let's keep rotating this a bit. Nice view of the coracoid process, kind of hooking forward. And then down underneath it here, we can see where that subscapular fossa would be located. The last scapular example I want to give to you is this model here, which is nice because it shows the articulations between the scapula, the humerus, and the clavicle. So again, hopefully you can tell from this perspective that we are looking at a left shoulder. Here's our clavicle again with our sternal end and the acromial end. And so you can see again how that acromion, the acromial end is articulating with that acromion of the scapula. And if we continue medially here from the acromion, we're going to be following along the spine. We have our supraspinous fossa and our infraspinous fossa. Here's our superior border with that suprascapular notch there. Medial border, lateral border. Then we can see our inferior angle, superior angle, and then the lateral angle is somewhat obstructed here because of these ligaments. And if we turn this around to the anterior side, we can see where that coracoid process would be, as well as how that coracoid process is attached even to the clavicle here. And then we can't actually see the subscapular fossa because it happens to have a muscle in it right there. This is the subscapularis muscle, one of the rotator cuff muscles, which we'll be discussing in the next lesson. Each upper limb consists of 30 bones. The arm has one bone, the humerus. The forearm has two parallel bones, the radius and the ulna. The wrist is composed of 8 bones, which are referred to as the carpals. The hand has 5 metacarpals, and the digits are composed of 14 phalanges. You can probably see a lot of similarities between the organization of the bones of the upper limb and those of the lower limb. And we're going to be using a lot of analogies here because you should already be experts at the lower limb because we've already covered them in this class. So as you can probably imagine, the humerus is kind of analogous to the femur of the lower leg. The radius and the ulna are analogous to the fibula and the tibia respectively. Instead of the tarsal bones in the ankle, we have carpal bones in the wrist. Instead of metatarsals in the foot, we have metacarpals in the hand. And then the phalanges still have the same names. The only difference is going to be that just as the big toe had a special name in the lower limb, the hallux, the thumb has a special name as well, the pollex. So we're going to go ahead and start proximally and then work our way distally down through the arm, focusing on those regions as opposed to just dividing it up by bone. So we already mentioned that the humerus of the arm is analogous to the femur of the leg. And the humerus also has a head, a neck, and a shaft, just like we saw in that bone. The shaft is pretty obvious. And the head is going to be at that proximal end that is articulating with the glenoid cavity. Now, as you look at the head of this bone, you can see that it's nice and smooth in order to help accommodate that articulation. But notice that the neck isn't anywhere near as pronounced as it was on the femur. The humerus actually has 2 necks, an anatomical neck and a surgical neck, and the anatomical neck is just distal to the head. So while this is going to be the head of the femur, the anatomical neck is going to be right about here. But do you notice here at this anatomical neck, we really haven't reduced the diameter of the bone relative to what it was at the head. I think in most cases you would agree that a neck has a smaller diameter than a head. So the humerus actually has a second neck, right about here, right when the diameter does start to decrease. And this is referred to as the surgical neck. It's called the surgical neck because if you break the neck of your femur, if you have a break in your femur around this region, it tends to be here because this area is smaller and thinner than this neck right here. So this is the one that tends to break and thus has to be surgically repaired. So the surgical neck. At this distal end, you'll also notice 2 large protrusions, one that is a little bit more laterally and one that is more medial here. Just as in the femur, we had trochanters just distal to the neck. and the humerus, we have what are referred to as tubercles. So use again this analogy to your advantage, because if you've already learned it once, that's going to make it easier to apply this time around. So the greater tubercle is located here on the lateral side, just as the greater trochanter was on the femur. And then the smaller, lesser tubercle is located on the more medial side, again, just as the lesser trochanter was on the femur. You'll notice that there's a shallow groove right in between the two tubercles. This is referred to as either the intertubercular sulcus, intertubercular in between the tubercles, or the bicipital groove. Now the latter name comes from the fact that this groove houses the tendon of the biceps brachii long head as it travels distally from its origin at the supraglenoid tubercle. Let's take a closer look at the distal end of this bone on the anterior side. So the distal end of the humerus helps to form the elbow joint by articulating with both the radius and the ulna. And at this end, we're going to find the rounded capitulum, as well as the trochlea, whose shape slightly resembles that of a pulley or a spool of thread. Now both of these structures are visible on the anterior side of the humerus, but if I turn this around so we're looking at the posterior side, you notice that now we can only see the trochlea. The capitulum is no longer visible here on the posterior side. So these two structures articulate with parts of the radius and the ulna. There are small fossa above each of these structures on both the anterior and the posterior side. So on the anterior side, the radial fossa is located just proximal to the capitulum, and the coronoid fossa is located just above the trochlea. On the posterior side, we're going to find a single large fossa, and that is the olecranon fossa. And as we'll see shortly, all of these fossa are named based on the structures of the radius or the ulna that occupy the fossa when the elbow is either flexed or extended. Now the capitulum and the trochlea together serve as the articular condyle, and the humerus has a medial and lateral epicondyle, as we've seen on the lower limb bones as well. So if this whole part of it is considered the condyle, then this is going to be the lateral epicondyle, and then we have the medial epicondyle as well. Both of these epicondyles will serve as points of muscle attachment. While we discuss the radius and the ulna, I want to use this articulated model so you can see how they associate with each other and also how they associate with the humerus. We're going to zoom in for a little bit on that proximal region of these two bones at the elbow. So just a minute ago, we were looking at a right humerus, and we are continuing to look at a right arm on this side. The humerus is just a little bit larger. I also want you to notice, and don't be tricked by the fact that this trochlea on the articulated arm has a little cut in the middle of it. That's simply to accommodate the hardware that allows these bones to articulate with each other. So the radius and the ulna are parallel bones that support the forearm. These are analogous to the tibia and the fibula of the lower leg. The ulna is slightly larger and is the medial bone, just as the tibia was in the leg. And the radius is slightly smaller, and the lateral one, just as in the leg, the fibula was the smaller and the lateral one. Unlike the leg, however, both the ulna and the radius articulate with the humerus. Recall that in the leg, only the tibia did, but in this case, we've got both of them that are articulating. And we're going to go ahead and begin by talking about the ulna. The olecranon process is the large, thick process that we're going to find on the posterior part of the bone. It's curved at its proximal end, and it kind of makes almost like a letter C as it's articulating with the humerus. The point where it articulates with the trochlea, is called the trochlear notch. So this is kind of the cup portion of the C. This is the trochlear notch. This is the point of articulation that is one of the two joints that make up the elbow, and this is simply called the humero-ulnar joint, which is a synovial hinge. So the humero-ulnar joint consists of the trochlea of the humerus and the trochlear notch of the ulna. If we look at the posterior side of the olecranon process, it's very large and very rough. This is the surface that you can actually feel directly on the back of your elbow. On this anterior side, if we look at the most anterior part, at the anterior tip of that trochlear notch, is where we're going to find the coronoid process. So this giant C shape that we see here on the ulna has the olecranon process, and then the tip of it on this side is the coronoid process. So what happens when this joint is either extended or flexed? So when the arm is extended, I want you to notice that the olecranon process fits into this fossa that we were just talking about on the humerus, which is the olecranon fossa. So again, when the arm is extended, the olecranon process of the ulna fits into the olecranon fossa of the humerus. Okay? Now, what happens when the arm is flexed with the ulna? Let's move on over here to the other side. Recall that we said this was called the coronoid process, and this fossa on the humerus was the coronoid fossa. So when the arm flexes, notice that the coronoid process of the ulna then sits into the coronoid fossa of the humerus. So, in other words, the fossa of the humerus are named based on the processes that actually fit in them. So, coronoid process into the coronoid fossa, olecranon process into the olecranon fossa. Before continuing on down the arm with the ulna, let's stay around the elbow here and talk about what's going on with the radius here, because we see a very similar pattern of nomenclature with the radius at the elbow. So while this articulation between the humerus and the ulna was called the humero-ulnar joint, right next to it, just lateral to that, is going to be the articulation between the humerus and the radius. And so as you might guess, this is called the humeroradial joint and is also a synovial hinge. So the elbow officially is two joints, the humeroradial and the humero-ulnar joint. In this joint, we see the head of the radius, which is kind of this round disc-like structure, articulating with the capitulum of the humerus. Now, I didn't mention this before, but capitulum actually comes from the Latin root caput, which means head. Consider the word capital, that's where the head of the state is in a government, or a baseball cap that goes on your head. So the reason this is called the capitulum is because it is associated with the head of the radius. So hopefully that might help you remember that. Now I want you to notice that again, when the elbow is flexed, not only is the coronoid process of the ulna going into the coronoid fossa, but look what goes into the other fossa of the humerus. When this elbow is flexing, we see the head of the radius fitting into that radial fossa of the ulna. So again, the articulation occurs at the capitulum, and when that flexion happens, I'll show you here and again, the head of the radius is going to go into that radial fossa. In this case, the fossa is named based on the bone that is going in there. It doesn't have to be named after parts of the bone because this is the only place where the radius is going to articulate it with it. Now, just as there were 3 points of articulation between the tibia and the fibula, there are also 3 points of articulation between the ulna and the radius. The head of the radius is part of the proximal radioulnar joint, and there's also a middle and a distal radioulnar joint. At this joint, at the head of the radius, this head of the radius is going to sit in a notch that's on the ulna that's called the radial notch. So yet another example of a depression being named for what fills it. This articulation is probably better illustrated on the separate bones. So again, if we look at this radius here, we can see the rounded disc-like structure that makes up the head of the radius. And if we look at our ulna here, we've already talked about the olecranon process, the trochlear notch, which you can get a better view of, coronoid process. But then just lateral to that coronoid process, you're going to see another little divot, another little notch here. And that is the radial notch, because that is the notch where the head of the radius is going to fit so that they can rotate around each other. So that is the articulation that makes up the proximal radioulnar joint. Again, the head of the radius articulating with the radial notch of the ulna. This joint is a synovial pivot, which is the first time we've seen this joint that talked about this type of joint, this structural classification in this class. And it's one of the articulations that allows you to rotate your arm between a palm up and a palm down orientation. So what exactly do I mean by a palm up versus palm down orientation? This here is the articulated arm again, and it's the same anterior view that we've been looking at. And this is the palmar side of the arm. So as this arm is sitting here, like this right arm, it's almost as if my arm were here. Now I can take my arm, and without really any motion occurring in my upper arm, I can tilt my hand, my palm, to the table. This skeleton can do that as well. And when that process occurs, that action occurs, it's happening at this proximal radial ulnar joint, as well as the distal and the middle ones. But just to show you how that pivoting occurs, again, without moving the humerus at all, I'm going to leave the humerus in place. This can rotate palm down and palm up. Palm down, palm up. This orientation, this quote palm up orientation, is referred to as supination, and pronation is putting it in a palm down position. So this is pronation and supination. One way that people remember this is to think about how you would orient your hand if you were carrying a cup of soup. You would obviously want your palm up in order to carry that soup. And so this is that supinated part. And again, just as we were talking about it a minute ago, that joint, that proximal radial ulnar, the head of the radius is sitting in that radial notch of the ulna. You just can't really see it very well on this individual arm because the notch is being obstructed by the head that's articulated there. Before we continue down to the shafts of these bones, I did want to point out a couple other additional structural features that are here at the proximal end. Let's go back to our radius for a second. Recall that we've already mentioned the head of the radius, and then notice how just distal to the head, the bone narrows a little bit. And as you might be able to guess at this point, that's the neck of the radius, so the narrowed part of the bone just distal to the head. If we keep heading just distally here, you'll see this rough patch that I'm just putting my pointer over right now. That is the radial tuberosity. On the ulna, we see something very similar. So we have that coronoid process, and then just distal to that, we have a rough patch on this bone as well. That one is the ulnar tuberosity. Both the ulnar tuberosity and the radial tuberosity are going to serve as attachment points for both the brachialis muscle and the biceps muscles. Again, seeing the same pattern in the upper limb as the lower limb, we also have a middle radial ulnar joint that occurs between these two bones. They both have interosseous borders to them with an interosseous membrane in between, and this forms the middle radial ulnar joint, which is a fibrous syndesmosis. Again, exactly what we saw in the lower limb. At the distal end of the arm, we can see where the head of the ulna now is going to articulate with the ulnar notch of the radius. So now one thing I did want to draw your attention to is that in every bone that we've talked about thus far that has a head, the head was located at the proximal or more superior part of the bone, which might be the intuition given where your head is located on your body. The ulna is the exception to this rule. So while the head of the radius is at the proximal end, the head of the ulna is going to be at the distal end. So the heads are at opposite ends. Now, as we said before, the head of the radius sits in the radial notch of the ulna, and the head of the ulna is going to sit in the ulnar notch of the radius. Let's take a closer look at that. I'm going to bring to you one of the radius that we were looking at before, although I will say that this is a left radius, not a right radius. But we can see here where that same notch is that my finger is sitting in right now. So that's the ulnar notch. The other thing that we can see on this distal side of the bone is this kind of little pointed process right here, and that is the styloid process. We see a similar styloid process on the ulna, it's just a little bit smaller. So on the lateral side of the ulna is where we're going to find the head. The medial side of the ulna is where we're going to find the styloid process of the ulna. And because these two styloid processes don't have any other parts to their names, you do need to note that they, of which bone they belong to. Again, looking at this one, we can see here on the anterior side of the radius, and then we head over to the lateral side by the thumb, and we can see that styloid process. If we keep looking around here, now we can get a good view of the styloid process of the ulna as well. And then the head of the ulna down here on the more lateral side of the bone where it's coming into contact with the radius. This model is an articulated left hand in a palm up position, so in a supinated position. So this would be the equivalent of a hand in this orientation. So if we were to go ahead and turn it this direction, it would be like that. We're going to be looking at the bones of the wrist, the 8 carpal bones, from this perspective here, but I'm going to zoom in a little bit so you can see these bones more closely. The wrist contains 8 carpal bones that are arranged into a proximal and a distal row. So our proximal row here of 1, 2, 3, and 4, and then the distal row 1, 2, 3, and 4. These are, starting with that proximal row, the scaphoid, the lunate, the triquetrum, and the pisiform, which means P-shaped, so that might help you remember that one. And then our distal row, the trapezium, trapezoid, capitate, and hamate. So there are a few different tricks that you can use to remember these. Most of them have to do with mnemonics. And these mnemonics are all starting with the proximal row and going in that same direction that we just recited them. But the 2 mnemonics I'm going to teach you take the distal row in opposite directions. So we're going to start with the first mnemonic. So scaphoid, lunate, triquetrum, and pisiform. So S, L, T, and P. So we're starting at the thumb side, so it's so long to pinky. We've ended up here at the pinky. Then behind that, the hamate, the capitate, the trapezoid, and the trapezium. Here comes the thumb. So again, so long to pinky. Here comes the thumb. And then the second mnemonic that I want to teach you starts out the same direction. Some lovers try positions that they can't handle. Some lovers try positions that they can't handle. Personally, I prefer the second mnemonic, not necessarily because of the humor involved, but because of a few extra tricks in there. So you'll notice that there are 3 bones in here that we've talked about that all start with T. So that often causes trouble for mnemonics when words have the same starting letter. But in this case, this gives you an easy way to distinguish between them. So first of all, trapezium rhymes with thumb. So you can always remember that. Trapezium rhymes with thumb. Now, to tell the difference between the triquetrum and the trapezoid, recall some lovers try triquetrum positions that they can't handle. Trapezium, trapezoid, capitate, hamate. Just make sure that you're comfortable identifying these not only from the palmar view, but also from the dorsal view, because they do look slightly different in this case. So for example, here's our scaphoid, some lovers, lunate, triquetrum, but we have to peek at that palmar side before we can see the pisiform. That trapezium, they trapezoid, can't capitate, handle hamate. So now that you're all experts at identifying the bones that make up the wrist, now let's talk about the wrist joint itself. So the wrist joint actually consists of multiple articulations. There is the radiocarpal joint, which are the articulations between the radius and the carpal bones, and then also the intercarpal joints, which are the articulations between the individual bones themselves. So the radiocarpal joint involves the distal articulating surface of the radius and 3 of the 4 proximal carpal bones, the scaphoid, the lunate, and the triquetrum. You can't really tell from this angle. I know in this specific model it looks like it's just articulating with the scaphoid and the lunate, but based on the orientation of the wrist, it will also articulate with that triquetrum. The radiocarpal joint is a condylar joint, a synovial condylar joint, that allows for the flexion and extension and the abduction and adduction of the wrist, along with the circumduction. So all those intercarpal joints, however, are synovial planes that allow for sliding and some slight twisting movements there. Although it looks like it might, the ulna does not actually articulate with any of the wrist bones. There's an additional space in there that separates those two sets of bones, so that there is no such thing as an ulnar carpal joint. It does not exist. There's only the radiocarpal joint and then all of the intercarpal joints that make up the wrist. So how about the rest of the hand then? Next come all of those metacarpals, and those are just conveniently named metacarpal 1, 2, 3, 4, and 5. And then we finally get to all of the phalanges. So digits 5, 4, 3, and 2, we have proximal phalanges, and we have middle phalanges and distals. When we're looking at digit 1, however, we only have a proximal and a distal. And in addition, those can be called the proximal and or distal phalanx of digit 1 or of the pollex. And the pollex is the name that we use for the thumb, or specifically for digit 1. Other joints that we can look at here, there are also carpal metacarpal joints between the carpal bones and the metacarpals. There are metacarpal phalangeal joints, and then interphalangeal joints, as we talked about before. So all of the interphalangeal joints are going to be hinges, just as they were in the lower limb. Things get a little more complicated, and there's a little more variability as we start to look at the carpometacarpal joints and the metacarpal phalangeal joints. The good news is everything is the same between digits 2, 3, 4, and 5. The only one that shows any variability is the first digit. So let's talk about those. Let's start with the carpometacarpal joints. Carpometacarpal joints for 2, 3, 4, and 5 are all synovial planes. Those are all synovial planes, just as the intercarpal joints were. The very first carpometacarpal joint, however, is a synovial saddle. And this is the second example we're now seeing of a synovial saddle joint. The first one, if you recall, was the sternoclavicular. This is only present in the thumb. This is the joint that gives you the ability to touch your thumb to all of your other fingers. That's why you can do this with your thumb and not with your big toe, for example. So that's a synovial saddle. When we get to all of these, the metacarpophalangeal joints between 2, 3, 4, and 5 are all synovial condylar joints. These metacarpophalangeal joints are the articulations that you would typically refer to as your knuckles, okay? And those are condylar joints because not only can you flex and extend those joints, but you can also abduct and adduct them. So those are the different planes of motion that those joints are accommodating. But what about this first one? This very first metacarpophalangeal joint is actually just a straight up synovial hinge. Okay? And if you take your thumb and really pay attention to that joint, you may think you have more movement there, but most of the movement most of the flexibility and range of motion associated with the thumb is actually coming from that first carpometacarpal joint. So again, if I just put my hand here as an example, any kind of this additional motion I'm doing with my thumb, notice how all of this is occurring at this articulation right here, not this one. No matter what I'm doing, this bone and this bone are staying essentially in line with each other. All I can do with that is a hinge joint, just a hinge. That's all I can do. If I try to abduct and adduct, that's actually occurring down here. It's not occurring at that joint.